It took me years of POCUS training until a mentor finally helped me understand something I see overlooked all the time. The ejection fraction does not equal the cardiac output. In this video, I want to break down why you need to separate these two concepts in your head to better understand the function of the heart in the acute care setting. I'm Dr. Alex Estelle, and this is SonoCare. Let's start with definitions so we're clear on what we're talking about. The ejection fraction is quite literally the fraction of blood ejected from the left ventricle with any given heartbeat. It's often the headline to any echocardiography report and has important implications on the long-term health of the heart. It's measured by the Simpson's biplane method, where the end diastolic and end systolic areas of the left ventricle are measured in two orthogonal planes to estimate the fraction of blood ejected. The normal range is from 50 to 70%. The ejection fraction provides us a good estimate of how well the myocardium contracts, but does not provide us any information about the volume of blood pumped. Cardiac output, on the other hand, is the volume of blood pumped every minute. It's estimated after measuring the diameter and velocity time integral of the left ventricular outflow tract. If that technique's not familiar to you, make sure you check out my video here on how to do a cardiac output assessment. So unlike ejection fraction, cardiac output estimations give us a functional assessment of the heart's pumping capability. Now let's look at how these two concepts play out clinically. At rest, a normal heart has an end diastolic volume of about 100 milliliters and an end systolic volume of about 40 milliliters, giving us a stroke volume of 60 milliliters and an ejection fraction of 60%. Now let's take a heart with an ejection fraction of 30%. This heart has naturally dilated with time to compensate for the decrease in its squeeze function, and it's increased the pressure in the left ventricle to allow it to move more blood. It now has an end diastolic volume of 200 milliliters, giving us a stroke volume of 60 milliliters. So while these two hearts have a different visual appearance, they have the same functional capacity. There are long-term implications for the health of the heart with the ejection fraction of 30%, but in the acute care setting, that's far less relevant. Because hearts with an impaired ejection fraction naturally dilate to improve their stroke volume, we can't assume that they're also functionally impaired. This is why it's so important for us to estimate cardiac output and look for signs of poor perfusion to better understand the functional capacity of the heart. Another clinical situation that has really helped me understand the difference in utility between ejection fraction and cardiac output is in differentiating hypovolemic and distributive shock. In both cases, a heart that is capable will maximally increase its contractility, appearing hyperdynamic with an ejection fraction above 70%. They are, however, two very different problems. Hypovolemic shock is a low preload problem with poor ventricular filling, low stroke volume, and low cardiac output. Distributive shock with preserved blood volume and less resistance to forward flow is characterized by an elevated cardiac output. So while the two hearts may appear very similar visually, they have two very different functional capabilities. Being able to separate these two conditions has helped me quickly sort out undifferentiated shock on many occasions and provide the right treatment to the patient. I hope these two examples have helped you appreciate how ejection fraction and cardiac output, while both important in their own right, provide us with different information, and while we can't always assume that the visual appearance of a heart tells the whole story. Cardiac output estimations are a very powerful tool in the acute care setting and one I encourage all POCUS users to get comfortable performing. I hope you found this video helpful. Now get out there and scan.